It's my real pleasure to introduce Professor Hanneke Hulst, who is now the CEO of the Centre for Brain Research at Auckland University. But Hanneke comes from the Netherlands with a long history in MS research. And so it's fantastic that we will have someone in the university system that has an interest in research. And in actual fact, the MS Research Trust is funding, I'm not sure whether you're aware of it, Hanneke, or not, but some research by a young researcher who is looking at creating stem cells from human skin. And the idea being that if you can do that, then maybe you can use the stem cells for remyelination in MS. Interestingly, when we first got the application, it was right at the opening stages of the investigation of the research. It was very much pie in the sky, if I can say that. But Dr. Ernie Willoughby, who's one of our trustees, talked to some of his Australian counterparts, and they said it sounds interesting. And we've supported the first 2 rounds of that research, and she's now got 3 year, $160,000 a year from the Health Research Council to complete it. So those of you that have been involved in helping us fund the Research Trust, and MS Auckland, MS New Zealand have been major contributors. That's the sort of thing that you can do with a little bit of money and some really, really intelligent people. So Hanneke, please come up and talk to us about your interest in MS, particularly around cognition.
Well, thank you, Neil, for this kind introduction, and very happy to be here. I was thinking this morning, this is not my first time I give a lecture like this, but it's the first time I do it here in New Zealand since I arrived 4 months ago. If I listen to my person before me, I'm probably not going back to the Netherlands because this country is very hard to not like. I will talk about the invisible burden of multiple sclerosis with you. And I thought before I really dive into that, and I know it's already late in the evening, you just had a little snack, little sugar. Let's start with the kind of thought experiment. So just imagine yourself, you're going to the supermarket, you have to buy 3 things. You have to get granola, you have to get milk. And you're standing in this aisle and you're thinking there was a 3rd thing that I have to buy. And you know it's very important. You really have to bring it home. But you cannot get to the fact, what do I have to bring? And then my question is, who of you recognize this situation? Please raise your hand. I see a lot of hands. So the good news is, don't worry. This happens. This is life. But for persons with MS, this happens once, twice, 3 times or more times on a day. And you can imagine that if something like that happens, that is a real problem. It doesn't only affect yourself, being unhappy in the supermarket or have to go back. It also influences how you function in your family, with your partner, with your children, or how you function at work. And why I'm mentioning this is because persons with MS usually get their diagnosis obviously in the prime of life, when a lot of things need to happen. We're living in a society that is really, really fast in how we have to move. I have to say, the pace in New Zealand is a little slower. But I still think if you struggle with your cognition, you have actually a huge problem in today's society. And exactly that's what I want to talk to you about in the coming half hour. So talking about the invisible symptoms, sometimes you may wonder, wasn't that known yet? What has happened? So I had to go back to the French neurologist Jean-Martin Charcot, who was the first to describe MS cases. And the fact is that he already spoke about memory loss in his participants or in his patients, impaired understanding, and slowness. And I think the slowness is really something like a slowed information processing speed, something that doesn't mean that you're not able to do it. It just means you require more time to get to the final product in your head. So he talked about it, he wrote about it, and then for almost 100 years, we largely stopped talking about it. When I, in 2008, started my PhD project in the MS Centre in Amsterdam, this was one of the things I wanted to study. My mother suffered from multiple sclerosis, and as a daughter from someone with MS, I thought the cognitive symptoms, the memory loss, was maybe the hardest to endure as a daughter. I think we didn't like the wheelchair, but we could still go wherever we needed to go. But it was the fact that she couldn't have the conversations I had with her from the past that was the biggest loss. So when I came there and I introduced, I want to study cognitive deficits in persons with MS, one of the main neurology leaders in the field, Professor Polman, neurologist in the MS Centre at that time, he said, "Oh, you're gonna look into cognition? That's just fatigue." And then he said, and then, there's another thing. You cannot measure cognitive functioning, but hey, good luck with your PhD, and I'll catch up with you later. Obviously, at that moment, I thought maybe this is the worst decision in my life, to go into a topic that's not really supported. But then, I think 3 years in my PhD, I got this phone call and him asking, "I have this patient in my consultation room. She has a lot of cognitive deficits. Can you please advise me what best to do?" And I thought at that point, we made the step that, yes, fatigue is influencing your cognitive functions for sure. Everybody knows if you're really tired, if you didn't sleep well, your cognition, your focus, your attention will be worse the next day. But it's not the same as if something is broken in your brain. The cognitive deficits will still exist even if you're not fatigued. So when I'm talking about cognitive decline or cognitive symptoms, I think it's important to know that not everybody will develop these symptoms. The estimates are around 43 to 70% of people with MS that will actually suffer from cognitive impairment at some point during the disease. The reason why this is such a broad range is that it basically means that we didn't do a lot of good research on the exact prevalence. But having worked with people with MS for 18 years now, I think it's fair to say that 1 in every 2 persons will actually suffer from cognitive decline at some point. If we're looking at what particular cognitive deficits we see, it's like with every MS patient, everybody is slightly different. The pathology is slightly different, but we do see some patterns. So especially the cognitive slowing, needing more time to actually fulfill the task is quite common. And I think for people that work, and I think you're all in one way or the other related to MS, I think we recognize this quite easily. The other thing we see is that especially the memory function, like the example in the supermarket, but also where did I put my keys in my house, that you just don't know where in the space you left your stuff. So these are the 2 most common cognitive deficits, but we do see the broad range, and the further the disease progresses, the more we see that other domains also get affected. Again, having that said, I think it's important to realize that this is not something that is just standing on itself. So this has a huge effect on how you interact with other people, how you function at work, how you function in your personal life, and how it actually, in the end, affects your quality of life. I have to say, having listened to Anna before, I almost don't dare to keep my talk, because I'm really a dreamer. I'm really thinking of a system, how I would like to see it, looking at this particular symptom. Having heard your talk, I think we have bigger problems in this country. And then still, I think, just dream with me for this 30 minutes. Even though it's impossible today, that doesn't mean it's impossible tomorrow. And let's start from there. But that's the disclaimer, that you don't think I'm totally out of my mind. And also, everything I'm going to say, it's not implemented in the Netherlands either. So even though I think we are a little bit further ahead, still there we struggle to really get this into the system. I think one of the important questions is to also ask ourselves, when do these cognitive problems actually start occurring? because that also means when do we actually have to start keeping an eye on them. And I'm going to refer to a research from long ago. It's basically already from 2001. And usually I would feel that's not a very good researcher if you come with such an old reference. But at the same time, this is today. It's still the best study that's out there. This is a study by Maria Pia Amato. She is a neurologist from Italy. And she actually started looking into cognitive impairment at the time of diagnosis. So usually people with MS at diagnosis present with physical symptoms, problems with the eye, muscle weakness, not something cognitive. It can be a first symptom, but that's very rare. So usually at the time of diagnosis, we don't even think about measuring cognition or cognitive performance. It's not even on the agenda. She actually looked into that, and she actually demonstrated that at the time of diagnosis, 75% of the patients do indeed not have any cognitive deficits. Having that said, there is still 25% that already has mild to moderate deficits at the time of diagnosis, if you look at the neuropsychological assessment. In my humble opinion, being a neuroscientist and working in the neuropsychology field, I would really wish for this 25% of these people to get proper support at that time already. She followed up this cohort 5 years later, and she actually demonstrated that 50% of the people with MS are still cognitively intact, no problems there. But the number with mild to moderate impairment has doubled to also 50%. And after 10 years later, she actually demonstrated that it sort of stayed stable. So this also indicates that in these first 5 years, the biggest change has happened. So maybe this is something that occurs already early in the disease. The fact is that I've wondered for a bit, like, why is it that we don't see these people? And I think there is several explanations for that. So if I look at the persons with MS, being in their prime of life, having busy jobs, having family with young children, whenever they feel they are forgetful in the supermarket, and if that happens 2 or 3 times, I usually hear them say, well, it's probably my children that are too busy, or it's my job that requires so much from me. So they are looking for external reasons as an explanation for the cognitive problems they experience. The neurologists, well, I almost don't dare to talk about it. They don't have limited time, and here there's even less time. So they are concerned making sure the brain pathology doesn't continue and that your treatment is well and adequate. And I'm not blaming anything, I think that's very important, but there is no urgency in talking about that cognitive aspect at that time. So when do we start speaking about cognitive impairment? That's usually when it's already very far advanced, when you have trouble at work, where there's a conflict, where your colleagues think you're a slacker because you're not doing your job well, or when you have trouble in your relationship. One of the things, and this is an anecdote, and I've asked her if I could share it because this really stuck with me for a long time. This was a couple. He was diagnosed with MS, and they were with me at a brainstorming session with all kinds of people with different perspectives. And she said to me, I'm so happy that I finally know that this cognitive aspect is part of multiple sclerosis, because and then she said, but I would have loved to know this a little bit sooner, because it could have saved us 5 years of couples therapy. And I said, okay. And then she said it was really hard because she thought he wasn't interested in her. During therapy, he promised to do better, but obviously he forgot. So he didn't do better, and they struggled quite a bit. And every person that says to me, well, you want me to talk about it, but there is no cure for it, they are right. There is not a pill that we can give and it's gone. But I think having your family, your partner, your people at work know that this is something that comes with the disease and it's not something you do on purpose, may already support that you can together and collectively can look for external cues and strategies to actually cope with it. Having that said, obviously for her on a day-to-day basis, nothing would change because he still would be forgetful, but she would have known it's not the love that was lost. She would have known that it was actually an unrecognized neurobrain pathology. And I think that makes a whole lot of difference for people's well-being and quality of life. So what we're standing at is actually that we're at a system level challenge. So we have people with MS not recognizing that it's part of the disease. We have neurologists that are burdened and overworked and not enough in number. And then we have this complexity of how do we actually manage this. So I think this is where we're standing today. This is where I was standing a long time ago in the Netherlands. And I said, well, we have to do this different. And I think we can do this differently. But where do you begin? And I think with every begin is that we have to say we have to start with measuring what we're interested in. So we have to get some kind of information on how is someone doing, referring to that paper of Maria Pia Amato saying at the beginning of the diagnosis, you already see that 25% of your people have problems. It would be great to have a baseline measurement. If something changed, you can actually immediately relate it to someone's own baseline rather than relying on general norm scores that are usually not as good as your own reference. And I think if you're not measuring it, you can also not recognize it. And if you don't recognize it, you can also not timely support it. And I think that would be something I hope you take at least away from my talk. Let's talk about it and support it. And support can be in several domains and several levels. One of the other things that I thought is it was also a shout out to action. So I think I realized that even though we have more neurologists in the Netherlands per person, they still have a lack of time. And especially if I talked about cognitive impairment in MS, they thought that I was this sort of like difficult person that wanted more of them because I wanted them to talk about something. They are not doing that every day. And that was when we started working on a digital tool to actually help them measure it. So what if we can come with a solution in the technical area that they may actually be able to get some information about cognitive performance without having too much energy put into it. And that was the multiple screener. And the multiple screener is a digital cognitive screening tool. It's on an iPad. And what I'm going to show you now is really like fresh from the analysis. So it's, I think, the first time I speak about it publicly. So what the tool actually does, it's a short, self-explanatory, automated scoring tool for cognitive impairment. So you don't need a nurse, you don't need a neuropsychologist, you don't need a neurologist, you just need an empty room where the person with MS can sit with the iPad and for 15 minutes do some tasks on this particular tool. And what we do in these 15 minutes is exactly the 3 cognitive domains that I already mentioned at the start: information processing speed, verbal memory, and viscospatial memory. We assess that in this 15-minute time span, and you get an automatic score, whether you're doing as well as expected, a little bit worse, or maybe you're doing better, and there's no need to talk about it. It has good usability and strong correlation with the paper and pencil test that we use. And also what Pauline Woskowiak just found out, that it's 70% of the time correct compared to a 2-hour neuropsychological assessment. So I think having 70% correct, you would say, well, that's not enough, it's not 100. But we're doing nothing now. So I think working with a 70% correct screening tool, I mean, it's not replacing anything, it's just a screen. Do we need to do something with this patient or don't we do anything? And I think being 70% correct could actually increase at least the attention and the support. And yes, I'm aware it may also ask more from the healthcare system at that point, but maybe not without reason. So I think we can do the timely identification, we can screen, we can get a conversation starter going, and also ask a question like, how are you doing? But then I often get the question, and what are we going to do next? Because if there's no pill, if there's nothing you can do further, why bother getting all this attention at identification? And as already mentioned from that anecdote, I think what we can do next is, first and for starters, do psychoeducation, help the person understand what's happening, but also involve the family, partner, children, and the workplace, if possible. Sometimes that's very sensible, but if it's not, I think involving your workplace could actually help you really get to better tasks and actually keep you in the workforce. It's not that I'm really pro work, but I think work comes with a few things that are very dear to people, which is financial independence, it's autonomy, and it's also a way of meaning to life for a lot of people. And that's why I feel so strongly about being in the workforce. The other thing we can do, which is also a psychological intervention, is the strategy training. So we can learn people compensatory strategies to not really solve the problem if your hippocampus, the part in your brain that is responsible for memory, isn't functioning well. I don't know if we can improve that. I mean, as a neuroscientist, I hope we can, but we're in that process. But what we could do is help you use internal and external cues to actually not be forgetful. If you set your alarm all the times, if you make your grocery shopping list, you will not forget your groceries when you're in the supermarket. So the result is that you will have a better day-to-day functioning in the presence of a deficit. And I think that can be really valuable for people as well. And then obviously, and that's the last part of my talk, what I would like to talk about is the brain training. Maybe we should actually look at the brain as we look at our muscles. We have to go to the gym every 1, 2, 3 times a week, maybe more. And if we stop doing it, it actually loses its capacity. So you have to continuously keep doing it. Maybe that works for the brain as well. And if we're looking into brain training, I have to say there is a lot of work been done in the community, in the scientific community. All kinds of different training programs, Brain HQ, there is group sessions. It's like, sometimes it's even with modified story memory techniques in progressive MS. There's lots of studies done. They all use limited numbers of participants. So the level of evidence is not that great. I think the effects are modest, usually not negative though. So basically you could say if it doesn't hurt you, it can only help you. At the same time, I also started wondering, like, if we do this, who are actually the patients or who are actually the people that can benefit most from these cognitive trainings? So if we're looking into responders and non-responders, can we get a clue for who does this actually work? Who do we need to prescribe this particular brain training programs? And what I'm going to show you here is a graph from colleagues from the UK. They did a 12-week training on information processing speed. It was a computerized, gamified function to actually improve that information processing speed. And they demonstrated on average that the participants improved 10% in information processing speed. You can wonder, what does that mean in daily life? Very good question. I'm not going to answer that today. But if you look carefully at this graph, we also see that there were 4 participants, so every bar is a participant. 4 participants actually got worse during the training program, so they got slower in their information processing speed. But because I want to keep it positive tonight, I want to pinpoint you to the other side, and that was also that there were a lot of people that actually benefited far more than the 10%. So our question was, who are these people that really have benefit by such a training program? We were obviously not the only one. There's a group in Buffalo, in New York, that does a lot of work on cognitive rehab and cognition. And they actually looked into a similar program. It was not the same as the UK, but also trying to improve information processing speed. And what they demonstrated is that the more you improved before and after a 12-week program, dependent on how much gray matter volume you had at the start. So the more gray matter volume in your brain, the higher the likelihood that you could benefit from such a training. I think we all know that with MS we have pathology in the brain, we have lesions. We also know that there is degeneration or atrophy of the brain, that it slowly reduces in volume. And having that said, the more you have at the start, the better you can learn. So thinking of the work of Maria Pia Amato that said it happens in the first time. Here, in the first period, you see the changes in cognition. Here we actually see that maybe when the brain is actually more healthy or more like the healthy, you have a higher likelihood of improving. So we did a similar thing. I was in Amsterdam at the time. It was a training program called Concentration Car, C-Car. So my participants had to drive for 8 weeks in a computer game in a Mini Cooper. And while they were on the road, they got assignments on the traffic signs. So here you see key L, and then a next sign came up, and they had to say whether the word existed if you combined the two. It could be that it was with algebra. Then when they came further in the training, the news went on, and they got all the sports results from last Sunday, and they still had to do the assignments. And then in the end, the petrol was emptying, and they had to refill it. That was the stage where I actually failed, because I'm well known for doing that the latest as possible. And that program didn't like that. But it was a way to train sustained attention, selective attention, divided attention, and alternating attention. We had 60 subjects that were involved in this, 45 minutes per week for 7 weeks in a row. And we had a waiting list control condition that didn't do any training. And we had healthy controls. I had a lot of anecdotes from people that really felt that they could do better. I had a cook in a restaurant that said, I have to prepare all these dishes, but I forgot. But after this training program, I only had to look once, and I was able to prepare all my dishes. But obviously, when I analyzed this data, it was like all the others, modest effect. It wasn't the Holy Grail. This was not what we're going to prescribe to people. And then I thought, but where are these people that have these good experiences? So again, we looked into responders and non-responders. And they didn't differ. They didn't differ in age. They didn't differ in educational level. They didn't differ in MS type, in disease duration. They were similar in the way how much brain lesions there were. I saw no differences in grey matter pathology like my colleagues in Buffalo, but I did something else, and that was when I looked at how brain regions are connected to each other. So using resting state functional MRI, I looked at different brain networks, and especially looking at the attention network. And this was an attention training, so you can imagine the attention network needs to be on, how that interacted with the general network of your brain at rest. And what we saw at that time is that the non-responders had a stronger connectivity between these two brain networks. And the responders had a lower connectivity. And I have to say, I was a little confused at that time. I was like, what's going on here? But I was very happy I included healthy controls there. So what we see here is that in a healthy brain, the connectivity is lower if it all works well. If there is MS pathology, the brain gets stressed, and these networks are going to be sort of like competing to sort of like deal with whatever is ongoing. So it actually demonstrated once more that when the brain is more lookalike of a healthy person, then you're more likely to benefit from a cognitive training. So that actually thinks that brings us a window of opportunity. And I think that means that when we have to talking about cognitive impairment, but also treating them, we probably have to do it with the least pathology present, because that probably is going to give us the best results, maybe even protective for what's going to happen in the future. It also means that we're slightly on a time clock, because maybe sooner is better than later. So that is when we started 3 years ago with the Don't Be Late study in the Netherlands, which is a study about preventive intervention on cognitive impairment. So we're actually including patients that have no complaints and no impairments, and we're treating them according to 2 different protocols. One is aimed at lifestyle, and the other is aimed at coaching at work, to see if we give them the support at an early stage, if that will actually mean that they will not develop problems over time. We have time to actually follow them up for a year. I would have liked to do this longer, but this is obviously the result of a funding scheme that doesn't allow us. So we probably will look for further funding to look further in the future. And our main outcomes are quality of life, but also cost effectiveness. So we will also look, are the people that were in the active treatments, are they going less frequently to their GP? Are they calling less frequently to the MS nurse? Do they feel better? And do they actually, maybe is the investment of the intervention it worthwhile along the end on a longer future? So to end up, I think what we have to do, or what we do in the Netherlands, is that we have, if someone presents with cognitive symptoms or cognitive impairment, if they have moderate to severe problems in daily life, usually you will get followed up, you will get treatment, you will be referred to a neuropsychologist, and they will try to solve the problems in day-to-day life. If you do have cognitive complaints, but you have no to minimal impairments in daily life, usually what's said to people in the Netherlands, well, maybe go away, we'll talk about it next time, we do the wait and see. Well, I actually think maybe this is already the group that you want to keep track on and maybe actually invite to participate to improve the cognitive functions and to make sure that you maintain what's still there. And to go a little bit further even, is that I think like if there are no problems, isn't that a window for us to say, well, you do have your MS diagnosis, that we know for sure. We know that 50% of you will eventually develop these symptoms. Shouldn't we go to primary prevention in that particular case and make sure that we maintain what's actually there? And I think that's what I'm voting for. Maybe we shouldn't focus on symptom management, but we should move to maintaining what's still there. And I think that aligns very much with how we currently treat the pathology as well, to really save the brain for as best as we can. So for healthcare providers, I would like to say recognize it, measure it, and act early. Be mindful that this can be there even though you're busy. Just try to do it. And it's really a shout out to every healthcare provider. I don't really mind whether it's a physiotherapy, a community worker, someone who actually figures this is important, open the discussion. For people with MS and their whānau, talk about it, involve your partner, involve the workplace, and do some checks. Is this really normal? Is this something that you see that I changed in? And then for policy and society, I would say invest early. I'm sure it will pay off, even though as a scientist, I have at this moment no ground to say that, but I'm still saying it. So what I would like to do is I would like to envision a horizon where we actually take care of people early, that we support them psychosocially from the very first start. You're living with MS. Luckily, you're not dying from it, but you're living for a long time with a disorder that is there every day. And what I hope is that it's there, but it doesn't determine who you are or how you function or how you want to live your life. And I think having an investment in this psychosocial aspect could really do great things there. Thank you for your attention.
It was wonderful. Excuse me. My name's Jan Campbell and I'm on the MSNZ committee. I'd just like to say that was so fascinating, and you're not a dreamer, you're someone with vision, and that's what we need. And thank you for having your inaugural talk in New Zealand with us.
Yeah, thank you. It's
At
really
Parliament.
great. It was really amazing. Thank you so much. Yeah.
If you can just bear with us for 2 minutes, we'll ask the speakers to come forward. We're going to have a Q&A session. I'll try and chair them, keep them in order. And who wants to be the person with the first question? Not you. Donald, I knew I could rely on you.
Somebody laughing back there. Yes, Hanneke, this is really an observation, doesn't require an answer at all. But when I was first diagnosed, formally diagnosed with MS, that permitted a claim against a rather handsome insurance policy. And the insurance company put me through 3 hours of cognitive battery tests. And I'm not sure why they did that. Doesn't require a comment, as I said. But I do find that it was interesting that my neurologist at the time never received the results of the testing that the insurance company had, I believe, tried to use to avoid the payout. Anyway, when was that? That was 14 years ago. Yeah. And I think I'm as bright as I ever was.
Hannah.
Yeah, I think, is it on? Yeah, I think in a way, I don't actually think that you always need to do a full extensive neuropsychological examination. I think a screening can actually do really well. If your screening is perfectly fine, there is no need to go into full testing. I think full testing is definitely a burden for people, but also it's stressful. And the other thing is you get better at it the more often you do it. So I'm also quite cautious about to really use it when you need to. And then the other thing is if you're being tested in a particular situation, I would be very much open to sharing that data to prevent people from doing it twice the same time. And even in a research setting, we are sharing our research results with the neurologist because, well, practice what you preach. If you feel it's important, we share everything. So Pauline did the work in 500 people, and she wrote reports for all 500 of them for the neurologist, even though that wasn't part of her PhD project.
Just a point on sharing information. Some of you will be seeing neurologists in private. In Auckland, at least, some of those private neurologists send a copy of the letter that they send the patient to the neurology nurse at Auckland Hospital, and that is something that is to be very much encouraged. So just a point, if you are seeing a private neurologist, please just check that a copy of the results of that visit go to the hospital, because if you finish up there in an emergency, knowing what the neurologist saw 3 weeks or 5 weeks ago could be very useful. Graham.
Thank you very much for your talks, both of you ladies. There's a lot of research at the moment, as I understand, on the MS prodrome. Is cognitive impairment one of those factors that they examine?
I don't know what they examine really, but I do know that from at least the Canadian studies where they have lots of data before the diagnosis, cognition is not really one of them. However, mood and changes in mood are, which usually can have an effect on the cognitive performance as well.
I know, looking back on my own diagnosis, I saw issues, cognitive issues. I used to joke that my facial recognition software was shot, and that was an issue way prior to my diagnosis. Thank you.
Any other questions? At the back there. Oh, sorry. Yep.
Thanks, Neil. Kia ora. I'm wondering about brain atrophy. Is there a relationship between brain atrophy and cognitive decline? And if so, how much brain atrophy do you need to have? And what questions should you ask about brain atrophy in terms of measuring it? And can brain atrophy be halted or reversed?
That's a lot of questions. So brain atrophy is definitely correlated to cognitive functioning, and more particularly the gray matter atrophy, as well as the atrophy of the thalamus, which is the central area of the brain that is predictive of cognitive impairment, however, only for 50%. So it means if you have atrophy, you have 50% chance that you will have cognitive impairment. So it also means the brain is a big buffer, and there are lots of people that have brain atrophy but no cognitive impairment, because there are other detours that the brain finds to actually get to that cognitive performance. It's actually one of the reasons why I started studying philosophy, because I felt really upset with the MRI because it didn't give me the answers to understand cognition. Your other question is it, I think we can hold it. I'm not sure if we can reverse it. So I think that's also why we're so much making the case protects the tissue from declining, because regrowing it, we know from animal work, it is possible, but in humans, it's very hard to prove, and it's indefinite or undefined at this moment.
There's a question over the back here. Have you got a loud voice?
You mentioned that the test on the iPad was 70% correct. How did you know what was correct?
It's a very good question. So we actually use the golden rule, which is like a complete 2.5-hour cognitive assessment that we know works in multiple sclerosis. So it follows the guidelines. Having that said, it's obviously not as good as a golden standard as when you have a blood measure, where you really know how much is in there, because it depends on what day it was, how good you were doing. But it's sort of like an extensive neuropsychological test battery measuring all the different domains, where you will be more complete about the cognitive picture. And then the 3 simple tests are 70% of the time correct with that very extensive assessment.
Question here.
No. Very interesting what you've shared with us. I'm just interested to know whether your research has reached a phase now where you can actually develop a framework of exercises that we with the condition can work on to strengthen our cognitive ability.
It's a question I actually asked on the last international MS conference, like to my peers. Do we think we're ready to come with a framework? I think we potentially could. At the same time, with all kinds of perhaps, maybe, but with the most likelihood. So I would really like to start working on that and to make some kind of flow chart. If you have characteristics A, B, and C, then this would be the most likely pathway to follow with the highest chance of success, which is obviously also always a chance and never a certainty. But we haven't done that yet.
We should give Hanneke a rest. Is there a question on the workforce? I've got one. Yes, Jan. You've got a loud voice. I put up with you on the committee for 2 years.
Anna, when I was looking at your data, I was wondering the line of the New Zealand workforce that if we were trying to attain that New Zealand line, or the Australian line for that matter, does it take into account current neurologists dropping off because they retire? Does it? Because
it does. So I showed you that diagram that was very complicated. I didn't walk through, but it incorporated retirement, new graduates hiring, retirement, population growth, not aging, which likely increases incidence. But yes, retirement. What it doesn't include is a calculation around attrition due to people moving abroad, but looking at it over the last 10 years, we have roughly the same ratio of overseas trained neurologists coming to us as we have attrition of New Zealand trained neurologists going overseas. So it sort of averages itself out. But yes, we did look at retirement.
And does it include the cohort that are private only?
We did include private neurologists.
Okay.
Yes. Yep.
Okay. Thank you.
Graham again.
As to the workforce, I guess it's a question that is going to be open, but as individuals, other than trainers and neurologists, what can we do to improve that horrific statistic that you showed us.
Well, I think the first thing we need to do is actually create more positions for neurologists. So we are currently training more neurologists than we have the capacity to hire into public sector jobs. So I think advocacy to increase the number of neurology positions at public hospitals is step number one. Then training, well, I mean, what else can we do? We can recruit people from overseas. We can train more students, we can have more jobs. And then the only other things we can do is become more efficient, use technologies like AI, look at alternate workforces, but so far we haven't shown that that fully addresses the problem. So I think it's a multi-pronged approach. Yeah, I'm not sure, am I fully answering your question? What are you looking for? Do you have an idea that you would like to share?
I come from Taranaki. There's a population of over 100,000 people without one neurologist.
Yep.
No specialist MS neurologist either, but I mean, no neurologist. How can we, other than talk to the people that are in charge of the funding and planning at the hospital, I guess that's what we can do.
Pretty much. Sorry, it sounds depressing, but it's not as dire as it sounds, because I think as a neurological community, we haven't done the best job in advocating. When I compare to other, I don't want to put any other diseases down, but there are some other areas in even chronic conditions that have done a lot better in advocating and raising awareness and saying this is really important and you need to do A, B, and C, and there are a lot more resources in those specialties as a result. We have limited resources, so we're kind of competing against each other, and we don't want to reduce care in other areas, but I do think proportionally we are particularly bad off. So I think advocacy will make a difference and does make a difference, because I know it's made a difference in other areas. So it doesn't sound like it's much, but I think we can do it. And I think also the other thing that we need to do is bond together. So, we look at MS, we look at stroke, we look at neuromuscular conditions, Alzheimer's disease. That's what the Neurological Alliance comes in. But if we combine and work together, and I think some other specialties, like cancer, for example, you have lots of different cancers, but they've combined into one thing. So if you talk about breast cancer, that's a lot harder to argue than all of cancer, but suddenly all of cancer is a really important cause of illness, and we need to work more closely together amongst clinicians, community with disease, and the NGOs, I think, to make a case. I think there is more we can do. So I don't think it's all depressing. I think there is lots of opportunity.
Anna, I find that comment very encouraging, because I think in my time with MS, we've often found the clinicians standing apart from us. In fact, when we, in 2014, got the first of the DMTs approved, of the new DMTs, there were clinicians out there that were quite surprised at the success that we had as a advocacy group. But we would be a lot stronger if, with the help of the neurologists, we were advocating, for example, for a neurological desk at the Ministry of Health, which is something that we've been advocating for some time and which the ministry has refused to have. So I find that, and you'll certainly find the MS Society very, very willing to work with you on those issues. Liz, there are lots of things that the Ministry of Health does that no rational people would put. Don't know whether there's anybody from the Ministry of Health here, but unbelievable, really. I mean, the facts are there. Neurological disease will overtake cardiac, and cancer is the biggest killer by 2040. I think I'm right in saying that.
I do think so, but I do think that it's a coordination problem, because when you look at cardiac disease, it's almost all ischemic heart disease. When you look at neurology, a lot of it is stroke. 50% of neurology probably is stroke, and we do have a stroke network. But then you have this problem that when the cardiac network, I don't know if anyone is here from the Heart Foundation, they just grab stroke. They say that's part of cardiovascular disease, and that's how they become number one, right? They just absorb us, and so we're kind of fragmented. So I think that we do need to come together, and this is also a little bit of a problem within the neurology community, and I'm at fault too. I'm a stroke neurologist, so I advocate for stroke. If you're an epileptologist, then that's what's important to you, and we need to cross those boundaries. So I think it's something evolving. I think it's also maybe a personality thing. So I think neurologists, and I speak for myself, we're pretty nerdy. You know, we like complex disease and like making diagnoses. We don't really like making a fuss. We're not really agitators by nature. And I think we're kind of people who like to get along with people, which makes us pretty nice people. But we need to be a little noisier and a little bit more aggressive, which I don't honestly think, and I have some of my colleagues here, and we're just not aggressive people. And sometimes you need to be loud and obnoxious and disrupt. And I think that this is the time to start doing that and getting encouragement from you all and you encouraging us to be disruptive. That's what consumers can do. You can give us a burning platform and say, be disruptive, you're doing it for us, because we're uncomfortable with it.
Question over here.
More common than questions. So I'm also at the Aotearoa University here in Wellington, and I'm a researcher and lecturer, and I work on MS research. And I'm training the new medical doctors. And what I've done over the last 2 years is that I've organized an MS Day for the new medical doctors. And Dr. Jenny Taylor has been part of this as well. And some of the community people. So we get people that are living with MS and talk to the new medical doctors and tell them that is very important. And it's not like, if I take your cancer as an example, that you get diagnosed with cancer and get treated and then hopefully get better, but it's a life-changing disease, and it's really different for people living with that. And so the students are really shocked when they hear what it actually involves, and it's really important that we're changing the perception of them to like what it is to be a neurologist. And so hopefully with this MS Day that I've tried to initiate 2 years ago, that we get more of the workforce coming for the neurologists.
Great. Any other questions?
I have a question. I'd like to ask my co-presenter.
Yes, you're allowed to, so long as it's not too difficult.
Oh, no, she'll be fine. She's much smarter than me. So my question is, I spoke recently, we have a neuropsychologist in Wellington Hospital in Aotearoa. Have you met her? She's from Finland, and she does neuropsychology in stroke patients. That's how we bond. But she had a lot of data to show that neuropsychology support and cognitive support improves outcomes, quality of life after stroke. And I was wondering whether there is something we can do as neurologists in looking at how we assess disability in MS. So we have this EDSS, which is very much based on physical health. It doesn't really have any significant, not much in the cognitive realm. And I see the same in stroke. We always focus on the physical problems, but when I've done lots of focus groups with patients across Aotearoa, and the complaints I always get is fatigue, and it's not just being a bit tired, like profound fatigue, inability to do things, poor quality of life because of cognitive problems that we didn't diagnose at the time of assessment in the hospital, and whether we're using the wrong outcome. So patient, related outcome measures, do we, is it right? Patient, anyway, problems. Yeah. So if we were as a community kind of reassess how we assess it, because then as neurologists, we would also shift how we assess people and use the cognitive realm. And that comes into the other question. So is this something you're considering? Could we work together across specialty? And do the disease modifying agents impact cognitive function, which I'm sure they do. And so would it be worthwhile measuring that?
No, I'm fine. Well, I think there are a few things. So I think definitely one of the things I'm thinking about is that we potentially should ask a slightly different question, but it may actually take more time. So I think what especially in a chronic disorder, the question could be, what is most important to you, rather than, and this is not a judgment. So I think There's a still very strong biomedical point to medicine. I'm just going to give an example. I was talking in Auckland about what matters to people and how do we actually get to that particular point. And I said, I, as simple neuroscientist, would say maybe ask that question to your patient. What matters to you? And then one of the neurologists there, he actually texted me and said, I tried to do what you were saying, and I got a totally different angle. So it was an MS patient with walking with a walking stick, having some physical problems. And he said, by nature, I would say maybe you should go to physiotherapy and work on your strength in your legs. Instead of coming with that advice, he started asking her, like, what matters most? And she said, well, what strikes me most is that my children are stigmatized for having a mother with a walking stick. And he said, suddenly my conversation with her was a completely different conversation, and it was also more enriched. And the outcome was still you have to go to physiotherapy, but also about how, no, but also to get rid of the stick, but also about what can we do for you and your family that this feeling of being stigmatized is not dominating your day-to-day life. And I think we have patient-reported outcome measures, and they are doing a great job, but we obviously don't know what we don't measure. So I think we have to start asking the question, what matters to people in Aotearoa New Zealand to have a valuable life? And to come to your second reach out, I would be very happy to do that transdiagnostically, because I don't think people probably differ that much. So maybe the diagnosis is not that most important. It is important for the treatment. It is important to finding the cause. But to have people live a valuable life, we may actually share a lot of things and we can collaborate differently.
I think that might be a good point to wind up the evening, and I just invite Steve to come and close for us. No, stay there.
Thank you, Neil. I would just like to wrap up here with a few comments. It's very hard to follow what's been said earlier, but I'd like to thank both our professors here today, Anna and Hanneke, for their insightful presentations, and to MS New Zealand and to the MS Research Trust for organising this event. And of course to Todd Stevenson, who I imagine is back in the house now, for hosting us in this chamber. I was delighted when I heard that it would be, that the conference this year would be in Wellington, no flights to worry about, and like Neil being stuck in Koru Club. If only I could get into that, I'd be very happy. And I'm now looking forward to future events being held anywhere but Wellington, so I can just sit at the back and take notes. So I will just wrap up. We're all here tonight because we are connected by one thing, and that's our interest in MS. Many of us are here because of lived experience, either our own experience or a loved one. In my case, I joined the Wellington MS Committee in 2015 after my wife received an MS diagnosis. That means we all understand really well some of the challenges presented by MS and how it can make everyday life difficult for both the person with MS and their whānau, and how it can affect careers and family and futures. Incidentally, I saw a little note here. My wife is my speechwriter, by the way, so I'm just about Alan Osmond, who one of the famous Osmond family that I remember. I didn't go out and buy puppy love, but I do remember the family. He passed away very recently after battling MS for over 4 decades. And he had lots of wonderful mantras, including when one person gets MS, the whole family gets MS. And I might have MS, but MS doesn't have me. And I think these sentiments are really interesting to share when we're trying to spread awareness of MS. As we're in Wellington, and as I'm on the committee, and as our community advisors are here, I'd like to acknowledge them. community advisors across the country are the backbone of the services that the regional MS societies offer. I'm really impressed by the high quality of the service we do offer and the commitment and dedication of the staff that we have. I'm also impressed, and I'm not easily impressed, by the high quality coordination, training and support that we receive from MS New Zealand. It's been about 10 years since new disease-modifying MS treatments became available in Aotearoa, which has been a game changer for many people with MS to access them. But it's important to remember that the search for a cure continues. I've been impressed by, I said I wasn't easily impressed, but I'll keep saying how impressed I am. I've been impressed at how quickly the new research and understanding can at times be shared and adopted within the New Zealand context. But while some of the obstacles within the system have been addressed, including better access to MRIs for people on disease-modifying therapies, there's many challenges remain, and I think a lot of those have been pointed to tonight, including the shortage of neurologists and other medical specialists. Wellington's very nice, as you know, come and work here, that's all very good. The regional variations in accessing services, shortage of funds, staff, expertise, machinery, the list is quite long. We know that time matters in MS. Early diagnosis and treatment remains vital to unlocking the best futures for people with MS, and this can only be achieved with another step change into the future. And the bold future that has been outlined tonight by our speakers is certainly compelling. We thank you for your dedication and help to find solutions to the challenges faced by people with MS in our health system. And research such as yours tonight that you've explained certainly drives future progress. So Neil, Amanda, the MSNZ team, you have an important part to play in unlocking that future. Thank you for your advocacy, ensuring that people with MS are not forgotten and that our voice is heard on the national stage, along with the other important work you do. It wasn't specified here, but I know there's plenty of it, so thank you for that. Finally, I'd just really like to say thank you to everybody that supported us tonight here. The audiovisual crew, amazing. The woman that poured me a drink, thank you very much. I said to her, if I come up for a second one, do not give me one. And she was good as her word. So I'd just like to say thank you very much for coming along, and I'll see you not in Wellington at another time. And, oh, sorry, I beg your pardon, the biggest thank you of all, everybody who came along tonight. It's been really well attended, and this is what, just raising awareness and that's all about. So thank you, and good luck editing that. Thank you.